Hello, everyone, and welcome to our first Mentor Monday in 2018. We took a break over the last few weeks for the holidays. I hope you all had a wonderful holiday season and are ready to kick some butt in 2018. It's going to be a very exciting year. I want to welcome with us today, we have my lovely co-host and producer, Jamie Cooper, and Dr. Chemanthi Kalen of Labs. And she's going to be talking with us today about cannabis physiology and harm reduction. So she is actually with Labs in Canada. So she's going to be giving us some insight that hopefully we haven't heard before. I'm really excited to hear what you've got to talk about today, Doctor. So before we get started, a lot has happened in the cannabis world since we last spoke, including our dear Attorney General reversing the Cole memo. It's kind of sent us all into a panic, and I've been pretty anxious to talk to you about it, Jamie. What are you hearing in Michigan? What's the reaction been?
Oh my gosh, I think everyone's on the same page. We're just like, oh, there's a lot more uncertainty than we had like about a week ago. But it seems like we're all just moving forward still. You know, we're using our voices more, which is definitely important. And I think it kind of lit a fire under us all, and it made us realize what's at stake. And so right now, I think we just all need to unify as one and really express, like Oprah Winfrey said last night, that, you know, your voice is your biggest tool and we need to be using that. So right now, use your voice and really state how you feel about what's going on.
Yeah, and so those of you who haven't noticed, we've been reigniting the Be Brave conversation. Jamie has a Facebook group called Be Brave for Cannabis. If you have not joined that yet, please consider doing so. And she's right, we need all of our voices right now. And for those of you who may be still in the closet a little bit about your cannabis use or your interest in the industry, now is the time to speak up. I mean, look, it's not a shameful thing anymore. MSNBC round the clock was running this story about cannabis and how much it's needed and why we need it in the face of the opioid crisis and the opportunity for states to make money. So the world is catching on, and it's not any longer something to be shameful for being a part of the cannabis industry. So hopefully we are going to keep you up to date. We are going to have Christy Lunsford from NCIS on later. And did I say, is it NCIS or am I quoting it? NCIA.
The National Cannabis Industry Association.
Not the TV show. So NCIA, she will be here talking about regulations. I'm not sure whether she's going to be on today or tomorrow, but keep an eye out for that. You will not want to miss that broadcast. You will be able to talk to her live and ask her questions. Okay, so let's get into our broadcast today. Dr. Kalen, I'm really excited to have you on and very anxious to hear about this research that you want to share with us. So I'm just going to let you take it away.
Okay, I'm just going to pull up my PowerPoint presentation here for you guys.
And ladies, if you do have questions, please drop them in the comments and we will get to them at about the 30-minute mark.
All right, can everybody see the PowerPoint clearly?
Yes.
Okay, fabulous. So I'm Dr. Chemanthi Kalen. Nice to meet you all. Today we're going to be talking about medical cannabis. I'm just going to be doing a brief overview for you. A couple of disclosures before we start. So this presentation is based on medical research and my own firsthand experience. I'm a family doctor as well as cannabinoid medical doctor, and I've treated hundreds of patients over the past year with medical cannabis. I've worked with a company called the Cannabinoid Medical Clinic, and they're actually based in Canada. They have 22 clinics across the country there. And I've done CME talks, so continuing medical education talks in Canada as well. Most recently at the PriMed Primary Care Conference in Vancouver, BC. And I'm also the lead physician at one of their clinics in Kelowna, British Columbia. And then Dr. Amin, he is the Director of Operations here at Lab, where we're broadcasting from today. And Lab provides analytical testing services to the medical marijuana industry here in Nevada. So over the next 20 minutes, I want to briefly review some topics with you today, just to give you an understanding of why we use medical cannabis to treat patients with a variety of different symptoms. So we're going to talk about cannabis physiology, a bit about the most recent medical evidence, touch on the concept of harm reduction, and then just briefly review the Nevada State Medical Marijuana Program, lab operations. And then we'll summarize everything at the end for you guys before we open up the floor to questions. So when we talk about cannabis physiology, actually our own bodies make cannabis molecules, and these are called endogenous cannabinoids, or endocannabinoids for short. And there's two major ones. There's anandamide and 2-AG. And this system was discovered in the 1990s by an Israeli scientist, Dr. Ralph McCollum. And he actually showed that our bodies produce endocannabinoids in a similar way to how we make endorphins. And when we talk about endorphins, these are the chemicals that are released, for example, after you go for a run, you get that euphoric sensation, that happy feeling. That's related to the endorphin system. So it's thought that the endocannabinoid system and the endorphin system have a lot of similarities in our own bodies.
It's also what gets released after you eat sugar and when you drink alcohol.
Yeah. And the endocannabinoid system, so I just want a question here for you guys to think about. Is it found virtually in every organ in our bodies? True or false?
I'm going to say true.
Yeah. Anybody else agree or disagree?
I agree. I agree that it affects every organ in our body.
Mm-hmm. Yeah, that's absolutely true. It is a ubiquitous system. It's found throughout our bodies, and it's thought to be something we can't really survive without. And if we look at how it actually works, it's through these signaling cascades. So a way to think about it is cannabinoids are just a class of compounds or a class of medications that bind to receptors in the human body. And these regulate a variety of different functions, from sleep to appetite, memory, digestion, your immune system, cardiovascular system, pain perception, mental health. So there's a lot of different processes that are involved and regulated through the endocannabinoid system. There's two main receptors that it operates through. So these are the molecules that cannabis binds to in our bodies. So there's the CB1 receptors, which are found mostly in the brain and nervous tissue. And when these are activated, you get effects, including suppression of neurotransmitter release. So that's important in pathways that regulate chronic pain, for example. And then your CB2 receptors are found mostly in the immune system. And when these are activated, you get some more complex type of immunomodulatory effects. And so we don't fully understand everything about this system yet and how it works, but there is a lot of research going into it.
So, Dr. Kalen, is this why they are using it with treatments for cancer and things like that? So when we look at treating those kinds of illnesses, it's working within the immune system in the CB2, like you're showing here?
Exactly. Yep. And it's also being researched in terms of certain inflammatory conditions. And we'll talk about two of the main players, THC and CBD, and some of the research surrounding those. So speaking of THC and CBD, so these are phytocannabinoids. These are produced by the cannabis plant. And there's many, many different phytocannabinoids, but I just want to focus on these two today because there's a fair bit of research supporting their use. So THC is delta-9 tetrahydrocannabinol. It's a bit of a mouthful, but this is the psychoactive component in cannabis. So this is what gives people the high, the euphoria. And so this is what your recreational users are going to be seeking typically. And so this, although it does have more of a recreational purpose in that aspect, we do use it in medicine. It's a very good acute pain reliever. It can work on muscle spasms, some mood disorders, helps to boost appetite, improve nausea in some patients. We also use it for neuropathic pain management. It can be very effective. But in some patients, there is a risk of psychosis because of the psychoactive nature. In particular, patients who have any history of schizophrenia or any strong family history of psychosis, I'll steer away from prescribing THC for those patients because they are at increased risk. CBD, on the other hand, is quite different. So this is not psychoactive, and it can actually reduce some of the side effects from THC, such as the rapid heart rate, the tachycardia, or the paranoia.
Okay, so can I ask you something? I just found out about this, and I wish I'd known many times when I have taken too much. How is it that it actually works to reverse those effects or bring you out of being overdosed?
Okay, so the way it's related to the way that THC and CBD bind to the receptor, the CB receptors. So CBD actually blocks the action of the THC to an extent. So that's why it's so different. And so again, we don't fully understand how that works, but it is more so a counterpart to THC that can block some of its psychoactive type of effects.
So when I've got something that's a 1-to-1 or an 18-to-1, how are they working together if they block each other, if the CBD, how does that work?
So that actually, that's a great question. We don't know exactly how that works yet, but there is a concept that's known as the Entourage Effect. And so this relates to the synergy of all the different compounds in the cannabis plant. And so I often use this concept to explain to patients why they get such a different response to maybe a herbal product as opposed to a synthetic THC. Because in the herbal product, you have all your cannabinoids, you also have your flavonoids and terpenes, and those are what give each strain their unique taste and aroma. And so there's an effect that all of these molecules act together so that the impact of the whole plant is different and potentially better than any of its individual parts. And that's known as the Entourage Effect. Does that help answer your question there, Clara?
Yes. Yeah, I mean, the fact that we have to kind of also respect the fact that this is such new science because we haven't been able to really study it, that oftentimes I find that one question leads to another question that just kind of is like, well, we'd all love to know that. So exactly. Yeah, thank you.
Mm-hmm. So moving on to the medical evidence part. So there is a great document. It's a 400-page document actually that came out in 2017. And this is US state-sponsored data about the health effects of cannabis and the cannabinoids. So this document was compiled by a team of experts from many different fields. And what they did was review all the literature on the health effects of cannabis and some of the synthetic forms that we use in medicine since 1999. And so in their document, they came up with several conclusions, and they grouped these according to the level of evidence. So when they said the studies were conclusive, that meant they were really good quality studies, really no limitations. And then when they said substantial evidence, that referred to studies that were good quality, maybe with some minor limitations, but that didn't impact their ability to come to a firm conclusion. So those were two of the main categories. And then from there, the evidence quality generally got worse and worse. So if we look at some of their main conclusions, so they found that there was substantial evidence. So again, good quality studies showing that cannabis is beneficial for adults with chronic pain and different types of chronic pain, so nerve-related, musculoskeletal, rheumatologic. Also for patients with multiple sclerosis, which is a neurological condition, for their spasticity and neuropathic pain, as well as for the nausea and vomiting that's often associated with chemotherapy. There was some benefit with the oral cannabinoids. And then there were some studies showing that the short-term sleep outcomes improved with cannabis in conditions like sleep apnea, fibromyalgia, which is a chronic pain syndrome, other chronic pain patients, as well as in multiple sclerosis. For all the other conditions, they really noted there was not as good quality evidence, so things like glaucoma, irritable bowel syndrome or IBS, epilepsy. But that being said, we still use cannabis to help treat patients with some of these conditions, but really we evaluate each patient on an individual basis to see what they've tried in the past, make sure they've had a good trial of the conventional therapies if those are appropriate before considering cannabis. But I do have a lot of patients with epilepsy on types of cannabis like CBD. They do find benefit from those products, but it's important just to have that discussion, you know, according to like what you're prescribing and what the level of evidence is for that particular therapy. So yeah.
Can I ask you, so there's limited evidence about glaucoma, but before cannabis was in the news, I mean, everybody would joke that, you know, you treat it with glaucoma with cannabis, and yet there's limited evidence. And then, you know, most of us have seen Dr. Sanjay Gupta's series on weed on CNN, where they dealt specifically with children with epilepsy, and the parents were having incredible results. So what actually determines insufficient evidence to conclusive evidence when we've all seen it?
Exactly. Yeah, it's just the quality of the studies. So a lot of these studies were very small. They weren't well designed, and so there were a lot of confounding factors. So this was one of the issues why they couldn't say that evidence was conclusive, just because of the way the studies were designed and carried out. So I mean, definitely a big area for research down the road for essentially all of these conditions and the use of cannabis.
You know, it must be such an exciting time right now to be a researcher in cannabis because you've got a completely wide open field.
Yeah, I mean, it's really exciting. And, you know, we can see in the clinic, we can see the benefits that patients get. I mean, it's very obvious to us and really very limited side effects. Overall, I find cannabis is quite safe as long as, you know, the physician is knowledgeable about, you know, how much to prescribe and what dosages and what strains, you know, for depending on the condition. There's also a few of the prescription cannabinoids that we can prescribe. So these are a bit different than your herbal cannabis, but sesamid or nabilone, that is a synthetic type of THC. And it's FDA approved for chemotherapy-related nausea and vomiting that hasn't responded well to our conventional treatments. And I also use it off-label for patients who have chronic diabetic foot pain. It tends to work well for some of those patients, as well as for patients with post-traumatic stress disorder and insomnia. So the other one is dronabinol, which is another capsule synthetic type of THC. Similar to nabilone, also approved for nausea related to chemotherapy. And then we also use it for patients with AIDS related weight loss. It helps to boost the appetite, increase the weight. And then Sativex is actually a plant extract. So this one is not available in the US. It's available in Canada and several countries in Europe. But it's an extract from the plant that patients use as an oral mucosal spray. So just a spray by mouth. And it's a 50-50 blend of THC and CBD, which is used for patients, again, with multiple sclerosis, related spasticity and neuropathic pain. And so those are the prescription forms that we often end up using.
So two questions. One, are they going to get the psychoactive effects because it contains THC?
Yes, so that is always, especially with nabilone and dronabinol. I mean, those are synthetic THCs. You don't get any entourage effect. You just get, you know, your THC-related side effects. So I find a lot of patients don't tolerate it that well, especially when you get into the higher dose ranges. Sativex is, I find that's a bit more well tolerated in my experience. It's more balanced. So the CBD tends to help reduce some of the THC side effects.
And why would you prescribe a pill over a plant?
Well, because with the pills, often patients will have coverage through their private drug plans. And actually in Canada, Sesamet through the provincial drug plans is often covered as well to a great extent. So that's one, you know, the economical benefits of using a synthetic. But, you know, herbal cannabis in Canada is not covered really through any drug plans, aside from maybe through a patient's employment, they might have some coverage. But other than that, it's an out-of-pocket expense. And it can be very expensive depending on the doses that they need and the strains.
And so I have heard that there's a long struggle in the medical world to create something synthetic, but they haven't been able to actually capture the benefits of THC truly enough to be able to actually just replace the plant as a medication. And my guess is because, like you said, it doesn't have the entourage effect, and that is actually what makes it so effective.
Mm-hmm.
Is that right?
Definitely. Yeah, that's one thing, you know, we talk about with patients, you know, but a lot of them are willing to try the synthetic forms or the man-made forms. And then, you know, if those don't work after a couple months, then we rotate them over to the herbal product. So
do you find that happens frequently?
Yeah, really frequently. I mean, a lot of this is trial and error, to be honest, because we don't have guidelines right now to really say what we need to do in each case. So it's kind of a bit of an art and a science, and so patients understand that though, and they're usually really cooperative.
That's great.
Yeah.
Thank you. This is great information.
Good. So I'm glad it's helpful. So herbal cannabis, when we talk about the plant, I mean, there's no specific dosing guidelines, as I mentioned, but one thing the College of Family Physicians in Canada says is just start low and go slow whenever you're prescribing it, especially if patients are new to cannabis, if they're cannabis naive. You want to be cautious when dosing it. And in the literature, the average dose ends up being between 1 to 1.5 grams per day for medical users. But in practice, I see this is probably closer to 2-3 grams a day when it comes to the average dose patients need overall. So one thing that we do, though, for every patient is set functional goals so that we know the therapy is working. So, for example, patients want to work towards certain things like just being able to function better at work or being able to play with their kids with less pain. Being able to maybe taper off their opioid painkillers. So these are things that we jot down, and then every visit we reevaluate and see what the progress has been.
Is there any pain-related issue that you don't integrate cannabis in? That's like, this is not something we can treat with cannabis?
Not really, not off the top of my head. It depends on sort of the patient's other health conditions in a lot of cases. And we'll talk about, some patients cannabis may not be appropriate for, especially when it comes to cardiovascular disease. That's where it gets a bit tricky. So it's not so much the pain condition, because we have different strains we can work with for different types of pain, but it's more so the underlying health of the patient, which often will guide our therapy as well.
Can I just ask you quickly, because I have had many women, including myself, complain about heart palpitations and things like that, but I can't find anything online. And now you just mentioned cardiovascular issues. What correlation are you finding between those two?
Yeah, so cannabis, it actually excites our cardiovascular system, THC in particular. And so there is the risk of rapid heart rate or tachycardia or palpitations. But this I typically see with heavy users. And in the research, what they've looked at, it's more so the recreational users who are smoking it in high amounts every day. So it's hard to make a generalization based on those studies, but in practice, I mean, we always warn patients that, it could cause some tachycardia or rapid heart rate. So, that's why you got to start low and increase the dose up slowly. And then also when we talk about safety, the obvious things are, the psychoactivity with THC can cause some drowsiness too, some dizziness. So with elderly patients, we want to be very careful with how we dose it. And then smoking cannabis too has some harms that they've identified. So the National Academies Press, they found there was substantial evidence that long-term smoking can worsen respiratory symptoms. So like chronic bronchitis, increased cough, increased phlegm production with long-term cannabis smoking. And then cannabis smoking in pregnancy leads to lower birth weight. So there was substantial evidence showing that in the research.
I have a question for you. Sorry, Dr. Kalen. So when you say smoking, are these studies just being done on actually smoking the flower where you've got that heat and that combustion, or is it also being done on vape? So is it more about the smoke, or is it?
It's smoke. It's not the vapor. We really don't have very many studies looking at vaporizing at all. But it's primarily on the smoked cannabis. Patients smoking joints, essentially, that's what they looked at. And you mentioned the cardiovascular safety. So there wasn't, a lot of evidence showing that cannabis can cause a heart attack or cannabis can cause a stroke, but there were some studies saying that there's possibly an association. But again, these were done on patients smoking cannabis in high amounts, recreational population, not so much your typical medical user.
Define high amounts. What does research consider high amounts?
It's typically over 3 grams a day. That's typically, higher amount. Yeah. But then now there's some other studies in animal models showing that CBD and the lower dose THC might actually be beneficial in cardiovascular disease. So we kind of have this sort of yin and yang. We don't really know what the answer to that question is. Is it safe for patients with cardiovascular disease? But I mean, typically if patients have any uncontrolled heart disease, like if they have angina, they're using their nitro spray frequently, I'll stay away from prescribing THC for those patients and go for more so of a CBD only strain. Just because, again, we really don't know if it's safe for those types of patients.
I have a quick question. In Canada, are you seeing any, do you guys have the hypermesis syndrome?
Is that the vomiting?
Yeah, well, I mean, the only relief you get is like by a hot shower. And I mean, people just sit in the shower for hours because that's what provides them relief. Do you guys see that a lot?
I don't see that a lot, but I've seen a couple patients with it, and those patients were, using over 5 grams a day often, so very high amounts. And so that cyclical vomiting syndrome, it's just related to the chronic heavy use of cannabis. And so usually if we get them off it for a couple months, their symptoms will improve.
Okay. And can they go back to consuming cannabis, just maybe not as often or as much?
Yeah, exactly. Yeah. And maybe they might benefit from a different strain, like something with more CBD as opposed to the THC, depending on what condition we're treating. But yeah, that's not something I see very often, but it is definitely out there.
Well, and here's a question I want to ask. Do you think that maybe that's something that's being caused by toxins that are in product and maybe intensified through the extraction process? And I mean, and it's an adverse reaction to those nasty things that might be in a product, perhaps.
Perhaps, yeah. Like I can't really speak for the recreational users because we don't really know what's in the products they're using. But for medical users in Canada, the licensed producers, they really have to tightly control the quality of products. So they do need to screen them, for bacteria, fungi, all the other toxins. Because we also have, immunosuppressed patients using these products. So they have to be quite safe. So yeah, occasionally though there is some contamination. That's just kind of one of the risks. But overall, it is safe using cannabis products through the licensed producers there. I haven't seen any patients using medical cannabis with that issue. It's been mostly like the recreational. Yeah.
What causes vomiting? That part of it just is so baffling to me. I don't understand.
Yeah, so it's related to the CB1 receptors in the brain. Because there are centers in the brain that regulate emesis or vomiting. And so it's related to the signaling through those receptors.
Oh, it's so fascinating.
So much to learn. And our audience seems to be really enjoying the broadcast as well.
Great.
Now, do you find that when people start using it medicinally, that you're recommending 1 gram a day, 1.5 grams a day for medicinal purposes? Do you find a lot of patients really bumping up and consuming more and more over time as they're kind of building that cannabinoid tolerance?
Yeah, like if they really do bump it up though, like quickly, if they're escalating quickly, then that can mean they're developing cannabis use disorder, or which is a dependence on cannabis. And we'll talk more about that. But typically, if they're using amounts less than 3 grams per day, I don't see really high levels of tolerance in those patients.
Okay, thank you.
Before we continue, I'm sorry, Dr. Kalen, let's take some questions. It's 12:30, and this next smoking versus vaping, I'm sure we're going to get a lot of questions on. So let's see what we have so far.
Okay.
So we have one from Kelly, and she said, I would be interested in hearing your thoughts in treating opiate addiction and overdose with medical cannabis. I have read a few studies that noted a drop in opiate use and overdose rates in states with legal cannabis, rates worth examining 20 plus more %. To me, the numbers are significant and warrant further examination in how we approach the current opiate epidemic in the U.S. Is the general consensus among medical professionals positive in terms of exploring cannabis as a viable treatment option for addiction? That's a great question, Kelly.
Yeah, that is a great question. I actually have that statistic that you quoted there on one of my slides, that in states that have legalized medical cannabis, that there's been a 25% drop in opioid-related deaths. So, I mean, that's tremendous. But as far as the I guess the reception for physicians, you know, prescribing cannabis, it depends on how up to date they are. Really, like, I mean, we don't get any training on, you know, medical cannabis, or I didn't get any training. Neither did my colleagues when we were in medical school or residencies. So we kind of go into practice not knowing much about cannabis. And so it's difficult to say if the community as a whole is receptive. But I mean, there's definitely an increasing interest in using cannabis for patients, especially some of the more complex patients that we see at the CMC who have really tried everything, and you know, nothing else has worked for them. And so now cannabis becomes the next alternative, and often they get a great response. If they're already on opioids, what I see in practice is like patients are able to decrease the doses of the opioids. Some of them are able to come off completely, which is amazing. Patients report less side effects with cannabis compared to opioids in most cases, so less constipation. They're able to function better overall on cannabis as compared to opioids. And so I always send my notes, my follow-up notes, back to the physician who's referred their patient to us. And so in that way, we're trying to increase the education and show physicians, you know, that this therapy actually works.
Amazing. Thank you so much for the work that you're doing.
No problem.
Anything else? Any other comments or questions, Jamie?
No, that was Katie just commented and said she apologizes for being late. She said different studies are being mentioned. Where are these studies being done? Where's this info coming from? Canada, Israel? And I think you.
There are various different places, but like with the cannabinoid clinic I work with, they are doing research looking at getting patients off their opioids and benzos with the use of cannabis. So these are large studies now that they're trying to do and get really good solid data to present to the rest of the medical community, because I mean that's what we need, because a lot of the research right now is just, it's not really great quality. So what we need is some good randomized controlled trial type of data to present to the medical community.
And this is being done in Canada?
Yes, I know of a couple studies done through this company I work with, and I think there's other research going on all across the world as well.
Excellent. Okay. Anything else, Jamie, or can we get back to the?
That's it. That's the questions we have right now.
Okay. All right. Smoking versus vaping.
Yeah. So this is a hot topic, as you can imagine. I mean, in the clinic, we don't recommend smoking, period. Okay, so patients come in, they're smoking, they want to continue inhaling. So then, you know, they ask, what do we do? So vaporizing or vaping is the alternative that we present to them. So this is inhaling the steam from cannabis through a machine called a vaporizer. And so this is actually safer overall. From what we've seen, there isn't a lot of research though showing that in the long term it's safe, but we know that it has less odor. Patients get higher survival of the cannabinoids, so closer to like 95 to 100% as opposed to maybe 50% with smoking. So
wow,
they're getting
no idea.
Yeah, so they're getting more for their money actually with vaping as opposed to smoking, and they like that. And also with vaporizing, it doesn't heat up the cannabis to such high temperatures as smoking does. So you get more non-toxic byproducts as opposed to the cancer-causing toxic byproducts with smoking. So overall, I think it's a great way, another kind of harm reduction strategy that we use to get patients away from smoking. And so that's vaporizing. There's a number of other delivery methods though, because inhalation is very quick acting. Patients like that. Ingestion is the other option. So edibles like brownies or cookies. Oils is another option patients take by mouth. The onset is a bit slower and then it lasts for longer. One thing to note though is that edibles have to go through our metabolic processes in the body. So they have to be processed through the liver. And so there's some more unpredictability with the edibles. You can get some more side effects. So if patients are using edibles, I just suggest, you know, they're cautious with that, especially if they're new to cannabis, that they start at a lower dose and increase slowly, just so they don't get side effects. And if they do, the side effects are going to last for several hours. So that's something that we're always careful about.
I wanted to say this because I want to mention the innovative products that are coming out. And actually, I talked to a gentleman from a pharmaceutical company out of Canada last week, and they have some sort of product that they can add into edibles that make it consistent. It covers the taste and smell. So this product they puts in takes out the bad taste and smell. It onsets within 15 minutes, no matter what. And, you know, it's like you get 5 to 10 times the effect, and it's full spectrum. And so it's amazing that these products like this are coming out, because we have these things with edibles thinking, okay, well, it could take 30 minutes for me, or it could take an hour and a half. What's it going to do? But, you know, having these innovative products that are coming out to improve this type of onset for patients.
Yeah, I mean, that's fantastic. I have heard of that product as well. But one thing right now that's available is the oils that we use, and patients, if they take those under the tongue, that's called sublingual. So often that helps to circumvent some of this first pass metabolism through the liver. But yeah, when it comes to ingestion, if patients can afford it, I do like to start them on the oils, and that also we can do drop by drop and go slowly.
It really doesn't help that we as people really like to eat. I mean,
and we want it now.
Yeah.
How many times have people overdosed on edibles because it didn't do anything and I've been waiting for an hour?
Well, nobody has ever overdosed. Remember, nobody's ever overdosed.
That's right.
Yeah, definitely. It's but
really overdose on cannabis. Theoretically, like somebody would have to consume 1,500 pounds of cannabis over 15 minutes to overdose. So, I mean, that's realistic.
So when I say overdose,
yeah.
I wasn't thinking in that direction. I was thinking I've had too much. And I'm not like, what is it? What did you say, Jamie?
Overconsume.
Overconsume, because I don't like the way it makes me feel now. So somebody got me on the tip of saying that it was an overdose, but it's an overconsumption.
Overconsumption, yeah. And that's definitely something patients need to be educated on, I think. All right, so let's move on. So this is that list I was talking about earlier. So the College of Family Physicians in Canada, they published this document, which is basically a preliminary guidance document on how to use medical cannabis. And they say, you know, for some patients, dried cannabis may not be appropriate. So for example, in the really young patients under the age of 25, when the brain is still developing, cannabis may interfere with their neuronal development. So that's generally not a population cannabis is recommended for. If they've got any personal or family history of schizophrenia or psychosis, like we mentioned, stay away from THC. If there's any active addiction to whatever substance, you know, you don't want to be adding in another drug on top of that, even though it's unlikely, you know, patients could get addicted. Cardiovascular, respiratory disease, we mentioned. If they're pregnant, breastfeeding, cannabis is not safe for those patients. If they've got any active mood or anxiety disorder, you do have to be careful, not so much with CBD, but with the THC, because it can cause some worsening mood symptoms in some patients, depending on the strain. The sativa strains can be very activating and can worsen anxiety in some patients. And then patients who smoke tobacco, especially men who smoke tobacco, are at increased risk for addiction to cannabis, and then cardiovascular disease. Patients who are having other drugs like alcohol, benzos, or opioids on board can get over-sedated with cannabis, but it's unlikely that they would stop breathing because we have so few receptors in our brainstem for cannabis. The brainstem basically regulates our cardiorespiratory system. So it's unlikely that you can overdose on cannabis, but there is this potential to get over-sedated on it if you're using all these other types of drugs and alcohol. And then talking about getting dependent on cannabis compared to other substances like heroin, tobacco, I mean, you can see that the risk is very low of actually getting dependent on it. And rather than addiction or dependence, we talk about a different phenomenon, which is called the Cannabis Use Disorder. So this is defined by the DSM-5, which is basically the Bible of psychiatry. And so they define cannabis use disorder as 2 or more of these 11 criteria you can see, on the right there over a 12-month period. So some examples, patients, they're using cannabis in really large amounts. They can't control it. They're getting cravings. They're having impairment in their social life, in their work or school life due to cannabis. They're doing risky things like driving under the influence. They're developing a lot of tolerance, or they're getting withdrawal symptoms from cannabis use. So this actually is called cannabis use disorder, and it's something we screen all of our patients for. We use the CAGE aid tool, which is a simple questionnaire on everybody. We do urine drug screens, and we also have everybody sign a treatment agreement and informed consent, just saying, they're going to get their prescription just from one clinic, from one physician, and they're going to stay away from using illicit drugs. And we really monitor them closely for this.
It seems that this list defines how people act with every addiction.
Yeah, it's very similar, to any kind of substance use disorder. But with cannabis, I don't really see this very often, to be honest, but it's something that some patients come in and they're using, over 5 to 10 grams a day. It's definitely something that, we do need to be aware of. Withdrawal is a problem in these patients, because if they'll abruptly stop using their cannabis, they'll get, worsening of their anxiety or worsening of their depression. So those patients, we like to get them on lower doses to reduce that tolerance and withdrawal risk. And so that's what we work towards. Have you guys heard of this before, cannabis use disorder? Okay, yeah, it's fairly new, actually.
Where's over creativity? Shouldn't that be on the list somewhere?
Meandering thoughts.
Yeah, cravings for pizza.
Yeah, the munchies.
Short-term memory loss.
Yeah, as long as
it makes complete sense. And I grew up, just like we start drinking alcohol very casually, and for some people it turns into a big problem. Mm-hmm. And it's good to have that awareness of knowing exactly when it's too much.
Yeah, and like when it's too much is usually when it's interfering with your functioning. That's when it becomes, a true substance use disorder. And then harm reduction, there's that statistic that, again, in states that have given patients access to medical marijuana, we've seen the painkiller deaths drop by 25%, which is really phenomenal. And so this is a good example of how, we can use cannabis to help combat the opioid epidemic, which has caused so many overdoses and deaths related to overprescribing, not just in North America, but around the world as well.
It's amazing.
Mm-hmm. And then the Nevada Medical Marijuana Program, which I'm learning about now. So they've actually set forth a few conditions that are approved for the use of cannabis. So they say AIDS, cancer, glaucoma, PTSD, weight loss or wasting from chronic disease, such as AIDS, very common, and cancer, muscle spasms, seizure disorders, severe nausea, pain, and then some other conditions which may be approved by the state. So in Canada, the system is quite different because physicians there are more so gatekeepers of medical cannabis. So we are the ones who decide whether or not patients are a good candidate. As opposed to how it works here in the US, I understand that physicians will provide a recommendation, and then the state ultimately will decide whether or not they are approved. So that was Canada's system many years ago, but now it has switched to more so physicians being the gatekeepers of cannabis, which I think works really well. And we're able to prescribe specific doses and THC potencies too.
So do you feel that move is helping to destigmatize it among the medical profession in Canada?
Yeah, I think it's definitely helpful because now, we're able to become more knowledgeable. Like in the clinic, we know sort of what patients need for whatever symptoms we're treating. It's a lot of it is through experience because we don't have the research to back it up yet. It's coming. But I think it's helpful to know what strains and what products patients end up using. And so we can really guide the therapy and make it safer overall too.
And can any doctor recommend it? You don't have to be a medical marijuana doctor. You can be general practitioner.
That's right. Yeah, you can be like a GP. I mean, some specialists, like especially pain specialists, they also work with the company that I'm working with. We have some psychiatrists too. We have doctors from all kinds of different specialties. Yeah. So there is no specific certification for it, but it's more so experience based and just becoming knowledgeable, seeing patients, seeing how they respond, and just learning like that.
Amazing. Is this the last slide?
Almost. We're almost done. Just want to highlight lab operations, and Rinku is here if you guys have any technical questions, but essentially Lab, so they provide various different services like foreign matter inspection. They'll process moisture content, potency, terpenes, screen for microbes, bacteria, fungus, etc., and also test for residual solvents. So that's one of the main functions of Lab.
If you're in Canada.
So the Lab is not in Canada. That's here in Nevada. Yeah.
Okay.
So I'm right now acting more so as a mentor, a physician mentor with them. And then I hope to, so the medical director, Dr. Shah, he has other clinics. I'm going to be doing family practice and wound care with those clinics in Nevada once I get my license. So, so that's the plan.
All right, Jamie, do we have, before she summarizes, do we have any more questions? You're on mute, sweetie.
Sorry. It says, can Lab test the gel cap to see what actually is in the capsule?
I'm just going to turn that question over to Rinku here. Just
Hello, good afternoon, everybody.
Good afternoon.
Hi there.
Every matrix can be tested. We break down the product to its full form of THC or CBD that's included. And if it's a edible, if it's a whole candy bar, we break it down to its bare product. So anything can be tested.
Okay. So I'm assuming she's meaning the ingredients within the edible and exactly what ingredients are in it to make it.
So we only take, go ahead.
No, go ahead.
We only test for the most harmful stuff. So I remember previously you were just mentioning about solvents and all the harmful substances that could be in there that they use during the extraction process. So that's where the solvents are, and that's what we test for. So we check for ethanol, methanol, butane, hexane, all of these different types of pesticides and microbials to make sure it's safe for human consumption.
Okay. Okay, Roxanne says, thank you. She says, I need to test the products I sell. So, yeah, that's all the questions we have. I wanted to ask you, Doctor, exactly how do you have these conversations about cannabis and you being involved in the industry? How do you have those conversations with other medical professionals and talking to them and helping them open their mind to what this entails?
So basically right now, it's all about education, because the whole stigma around marijuana is incorrectly formed throughout many, many years. So basically just, presentations like this, educating our, patients and consumers will help develop this industry much, much, stronger and better.
Okay, great answer. Thank you.
Mm-hmm.
Okay.
And then I have another question that says, what is identified as a low dose? I noted that the slide stated that the average MMJ patient is 1 gram a day. I found this level is high.
So low dose, is typically less than 1 gram a day. 1 gram a day, 1.5 gram a day is more so an average. But it really depends on the products, because if patients are using a vaporizer, often they won't need even 1 gram a day. But if they're using edibles, you're getting more of an unpredictable type of response, they might need higher doses. And, I've had patients who've actually put 5 grams in their spaghetti and meatballs and actually divide this up over 3 days and use that as their edibles. So there's a lot of diversity, I guess, based on how patients will use their products.
Absolutely. Thank you so much. That's all the questions we have now.
Okay,
All right,
great.
Dr. Kalen, if you want to do your summary.
Yeah, sure. So like we talked about, the endocannabinoid system is found throughout our bodies. The bulk of the evidence, when you're talking to patients, you can tell them, it's for adults with chronic pain, for those multiple sclerosis patients who have spasticity, and then the chemotherapy-related nausea and vomiting. We've seen some good benefit with the different products, cannabis. And when you're dosing it, just start low and go slow. I think it's a good general rule of thumb. And consider the different delivery methods that you have available, from inhalation to ingestion. And then screen patients for cannabis use disorder and monitor for that. Always consider your state-specific rules and regulations. But overall, I think medical cannabis is a great alternative therapy for patients. The right patient in the right circumstance with the right condition will benefit greatly from herbal cannabis if it's prescribed appropriately. And it'll help alleviate their suffering in a lot of cases, which as physicians, that's our primary goal. So
Absolutely.
yeah, that's actually the end of the talk. So my contact info is on the slide there, and Dr. Almonds as well. Feel free to email us if any other questions.
Are you a part of Women Entrepreneurs in Cannabis, where we are broadcasting this now?
I am not yet, but I'd like to learn more about that.
So we would definitely love to have you in the group, because if anyone has any more questions that they'll leave in the comments, I'd like for you to be able to address them. And we also get a lot of questions. And one thing I'd like to explore, I'd actually like to have you back on at some point to talk about your work as a researcher and being a woman in cannabis. I should really understand after this conversation how much room there is to grow in this field of research, and how many different aspects you can approach it from. Yep. And it has opportunities for women both in Canada and the United States as career options going forward. So I would love to talk with you about that at some point as well, and have you weigh in on the group when it comes to discussing things that, there are so many women looking for a way into this industry. And if you have a medical background, if you have a science background, maybe consider reaching out to Dr. Kalen and asking her for her ideas on ways that you can get into the industry using your medical or scientific research background. So thank you so much for being with us today, Dr. Kalen. It's been just fascinating and so wonderful to absorb this information and be able to ask you questions.
Yes.
So
and thank you. Thank you for doing what you do.
Yes, thank you very much.
Yeah, because we need more medical professionals, and I'm always so delighted to talk to a medical professional, a doctor that really knows their stuff.
Thank you. My pleasure, guys. I really enjoyed today. So just let me know if you need me to answer any more questions anytime.
We will. Thank you. And thank you so much, ladies, for joining us today on our first broadcast of Mentor Monday of 2018. Please keep an eye out. We will be announcing fairly last minute the time that we're going to have Christy Lunsford on from NCIA. And she's going to be talking to us about these regulations, help put our heads straight a little bit about what this really means for our future in the cannabis industry, short-term and long-term. And we will be back next Monday with another Mentor Monday. Until I see you then, have a wonderful week, and we will see you soon. Bye-bye. Bye, Jamie. Thank you again, Kalen.